All right, today we're going to talk about examination of the eyes, ears, nose, throat. To start with, we need to set the stage when we talk about palpation of the area. When we lay our hands on a patient, which, as you remember, is the second thing we do after we've observed them, but when we lay our hands on our patients, we don't go immediately to deep palpation, we start with light. And you remember that from our physical assessment lecture. Let's start with the eyes. So when you're doing the eyes, you want to start with general observation or inspection. Catherine is my lovely assistant today. Just to keep us on track, we're going to go in a very standardized format. And before I move on, one more note I wanted to include. The examination of the eyes, ears, nose, throat, and neck is actually part of your upper quarter exam. So some of the things you'll see me doing are things that you've already learned in musculoskeletal or will learn in neuro, and I'm just giving you additional tools to add to your tool chest while you're working with that part of the body. So when we look at the eyes, we're going to look at the eye itself, the pupil, the eyelids, the sclera and conjunctiva. We're going to watch the patient's gaze, the movement of the eyes, their visual acuity, and in some cases we may consider fundoscopy. Today I'm just going to talk about it and I'll demonstrate how you'll do it, but I won't go into it in depth because many clinics don't even use that. But if you are faced with a situation where you need to use a fundoscope, you'll at least have seen one. So, when you're looking at the eye, again, remember that observation is the very first thing you do. You want to look at the patient's eyes as a whole in their facial structure. Remember that we're always looking for symmetry. We look at the position of the eyes on the face, vertically, horizontally, and their alignment. And when you're looking at prominence of the eyes, when we get to the endocrine system, we'll talk about hyperthyroidism and prominence of the eyes. The easiest way to do that is to actually get above and behind the client and look at it from above. And to get a little bit better picture, you can simply draw the eyelid up so you can see how prominent the eyeball is. You can also compare that to the opposite side. And then you look at the pupils. Remember that pupils must be equal in size and shape. They're normally round. There might be a slight inequality. Anything really less than half a millimeter happens about 20% of the population. To test for the pupillary response to light, you take your simple penknife, and again, let's be nice to our patients. We're not going to shine it directly in their eyes as if we're interrogating them for the CIA. What we're going to do is we're going to come at them from the side. This is best done in a darkened room, but for demonstration, I'm showing it to you in a lighted room. So you're going to come at them from the side, and you're going to look for the pupil's response to that light, the pupil that you're looking at, as well as the consensual response of the opposite pupil. So you want the patient to, or the client to look into the distance. Catherine, if you can just look at the far wall. And again, I'm going to come across. Now, I would normally be directly in front of her, but for demonstration, I'm off to the side. So the light comes from the side. We watch for the constriction. The light comes from the other side. We watch for the constriction. And again, not only in the pupil you're testing, but in the opposite one as well. Patients who have very dark or very light colored irises, you might have some trouble seeing this. So again, the key is to do this in a darkened room if you can do it. Then you want to look for accommodation and convergence, which is I'm going to hold the pencil or the pen light about 10 centimeters from the patient's nose, and I'm going to ask them to look at it. And as they converge, you should see that pupillary constriction, and you should also see the eyes converge on the object. So you would hold it there, look at it, and then look at the distance without turning your head, straight at the pen light, and then look into the distance, and then look at the pen light and look into the distance. And then you want to start, with your inspection, you're going to have to start touching the patient a little more closely. This is where you'll probably want to put on examination gloves just for the patient's protection as well as your own. Now that we've looked at the pupil and the eye as a whole, we want to look at the eyelids. Thinking about the eyelids as an integumentary structure, we want to think about what's underneath the lid, as in, go ahead and look straight ahead, Catherine, as in just tipping the lower lid down and seeing how perfused that lid is. Is there redness there? Is it normal rubor? Is it pale, which might insinuate that there's some anemia present? You can also look at the upper lid, although it's a little bit more difficult. So inspecting the lower lid, the upper lid, looking at the eyelashes themselves. What's the direction of the eyelashes? There are some conditions where the eyelashes turn inward and can actually cause scratching of the cornea. And then finally, you're going to look at how well the patient closes their eyes. I actually do this as part of the facial muscle test, so I'm going to skip it at this time. When you actually look at the lower lid, it's helpful if you can have the patient look up. Go ahead and look up, Catherine, because then you can see the color of their sclera, the portion of the eye that's below the iris. Looking at the color of the sclera, looking if there's any increased vascularity or varicosity of the vascularity. A little yellow coloring is normal. Not everybody's eye is completely white from top to bottom, but excessive yellowing or jaundice can be a symptom of hepatic or renal disease. Again, thinking back as far as accommodation and how the pupils respond, now we actually want to think about the function of the eye as a whole. So, once again, taking the pen light, you're going to check their gaze. And you guys have talked about this if you've talked about cranial nerves. So thinking about 3, 4, and 6, the easiest way to check all of that is to, first of all, start with that conjugate gaze, about 10 centimeters, and then what I want you to do, Catherine, is follow it as it gets closer to your nose. You want to see if they can follow it in. A little bit of nystagmus is actually normal, but if there's a strabismus, if one eye doesn't come in and the other does, that can be an anomaly. The next thing you're going to do is check all the quadrants. That's what I say. You may have heard it in a different way, but you want to check all the quadrants of your visual field. There's a couple ways you can do that. I'll just point out 2 of them. The first, the easiest, is to make a big X. So you start in the center, just follow the pen light without moving your head, up to the client's left, down to the right, and then up to the client's right, and down to their left. And again, observing if they have any difficulty following that pen light. The other method is to describe an H. So you start here, you follow it down like a goalpost, across, whoops, up, and then down. Sometimes I'll end a little faster than I should be, and back to the start. The only reason I don't like the H is I want to really see if they have that oblique motion, because we use that in function. We don't always look straight up, straight down, and straight to the side. Visual acuity is tested using the Rosenbaum chart. You all have been to the doctor's office and seen the large chart at the back of the wall where you get to read the numbers for your optometrist. That's a Snellen chart. The pocket size is a Rosenbaum chart. So you hold it about a foot in front of the patient and you ask them to read the lowest line they can. And that's all they have to do. And then the final test, especially if you're working with patients with a neurologic deficit, I like to check visual fields by occluding one eye. Go ahead and look straight forward, Catherine. And you want to make sure that you start out easy, but then make it difficult for the patient. So Catherine, I'm going to have you hold this so that you're facing the white side. Hold it in your left hand over your left eye. Just, there you go. So now we know we're just testing the right eye. And you're going to start, you keep your nose straight forward, don't move your head, and tell me, keep looking straight ahead. Tell me when you no longer see the pen light.
No.
Good. And most people, that's actually perfect, and no, I didn't pay her to say that earlier. When you move it in an arc, most people get pretty darn close to 180 degrees. That's the easy way to do it, but it's also easy for a patient to cheat. So then what I do as a follow-up is if I'm concerned about their peripheral vision, you keep your eye pointed straight forward, tell me how many fingers I'm holding up. It's harder. How many?
2.
Good job. So it might be a little smaller as far as acuity, but that's totally, totally normal. You would then repeat that on the opposite side. Thank you, my dear. And for a full visual field check, if you're really concerned about vision, you would want to test them not only peripherally, but upper quadrant, lower quadrant for each eye. Now, I mentioned about the fundoscopy. I'm going to demonstrate it, but not actually do it. So this is a fundoscope. It's got a nice, I have to take off my glasses, it's got a nice brow piece so that you can put it against your eye. I will tell you that it's easier to operate if you have it against your eye first so that you're not searching for where it goes before you go to your patient. The other thing is this one is not operating because I haven't plugged it in because I don't want to blind Catherine, but you want to make sure you know how your particular piece of equipment operates. How does it turn on and off, and what are the apertures that are available to you? So once you're familiar with your piece of equipment, and you know your focus actually as well, you want to get your eye right there, and then Catherine, you look straight ahead. You're going to again do this in a darkened room, and you're going to come at the patient from the side. Those of you who have been to the optometrist and sit through that horrible exam where they're shining the bright light directly in your eye and he's saying, okay, just keep staring straight ahead, and you're like, I'm trying, but I can't see anymore. That's what this is doing. That's why a lot of physical therapy clinics tend not to do it, because the net result, unless you're dealing with a lot of patients with vascular issues or diabetes, you're not probably going to find a whole bunch of stuff. But what you're going to do, again, the fundoscope gets to your eye, and then you're going to come in and you're going to get up close and personal with your patient. Notice that I've kept my hand here on her brow, not only so I know that I'm not going to run into her face, but I'm also trying to keep her eyelid as open as possible. So I come in and I go in until I can get actually a view in through the pupil, and I can see the inner structures of the eye, such as the retina, the fovea centralis, and the macula. But again, we're not going to do that in lab, and I don't expect you to be at all proficient. If you are in a clinic where they use this, get familiar with the equipment and ask your preceptor their best thoughts on how to use it. Now we're going to move to the ear. When we're looking at the ear, again thinking about function as well as structure, we once again have to start with inspection, looking at the ear. Then we move to palpation, and then the hearing test. The methods of testing hearing. The final thing is I'll show you how to use an otoscope, which is a way of looking at the deeper structures of the ear. When we're looking at the ears, just like the eyes, again, I would be directly in front of the patient. I'm looking at where it is in relation to the face, where on the head the ears are located, and my big thing that I'm always looking for is symmetry. As long as I see symmetry, I'm a happy camper. Then I'll look a little closer, not all the way up close, but a little closer, looking for drainage, any obvious lesions. Remember from the integumentary system, looking for things like nodules, papules, plaque, anything like that. Especially if you see a noticeable redness or drainage, that can be a sign of otitis media or otitis externa. So that's the big thing you're looking for. Then we're going to move to palpation, thinking about some of the conditions that can impact the skin and therefore the ear. Think about things like psoriasis or scleroderma that we'll talk about later in the course. So we want to get a sense of how pliable or flexible and also how tender the ear itself is. Again, be nice to your patients. Start out with light pressure, and I'm just sort of feeling for how pliable and how flexible her ear is. I would, of course, do this on both sides, feeling the texture of the skin, just like you would if you were doing any other part of the integumentary system. Some primary care practitioners will actually pull on the ear a little bit at this point just to give them a heads up of how uncomfortable it might be and whether or not there's going to be a challenge in using the otoscope. Then let's move to function of the ear. So the first thing is a gross test of hearing. It's called the whisper test because you actually stand about 1 or 2 feet away from the patient and you whisper a very distinct word, but something that's not usual. So don't whisper 1, 2, hello. Whisper something that they can tell the syllables. Something like baseball or cucumber is a good example. So you would whisper in one ear, at one side of the ear, and I would, let's just say I'll do baseball. Did you hear what I said?
Baseball.
Good. And then I'm going to go to the other side, and I'm going to whisper something different so that I'm not cheating with the patient. Watermelon.
Watermelon.
There you go. And it's done. Pause for one moment while I collect my thoughts before we go on to the next portion of it.